Thank you very much, Dr. Posner, for this very comprehensive overview. And I think we could state this doesn't leave any open questions. But on the other hand, it was so plentiful, so many data, that I think there is quite a lot of discussion left. And first of all, I would like to ask you, why do you think is there such a difference between all these meta-analysis results where induction chemotherapy doesn't really is of benefit for the overall survival of the patients, and then when looking at some of those studies, it seems very reasonable and very also working. What is the reason for that? What do you think?
Well, I think that first, the ability to apply chemotherapy during radiation and the strategic placement of the drugs when you give them and the place of surgery are simplified in the chemoradiotherapy setting. And so without the real appreciation of what the biology is of the cancer, we embarked on many induction trials in which patients received induction chemotherapy. There were delays getting to the surgery, delays getting to radiation, and we really did not understand the impact of this. I like to say that in 1978, when I started in the head and neck program at the Dana-Farber, Ralph Wexelbaum, who is the head of radiation oncology at the University of Chicago, would treat the patients for 4,500 centigrade. They'd take a week to let the mucositis die down and then treat them up to 6,500. This was what we thought of the biology at that time, and shortly after that it became clear that you didn't want to have a break in treatment. And as we understand the biology, I think many of the early trials which used inadequate drugs, had inadequate timing, would never have been allowed to be done today just because the science wasn't very good, are included in the meta-analysis and really diminish the efficacy of induction chemotherapy within the meta-analysis. That being said, despite this, the platinum 5-FU regimens, when they're teased out, and that's what meta-analysis allows you to do, to look for a trend, to see something that's inapparent when you look at individual trials, but look at the broad panoply of trials to identify a trend that you can then study and evaluate and take forward in a more rational scientific fashion. And so the induction trials really were much more complex in many ways than the chemoradiotherapy trials. I think that really explains part of the effect.
Andreas, do you also think that it's very critical, this time frame in induction chemotherapy?
I think Marshall pointed out in his presentation that there are different indications which have to be kept in mind. I think one point which is very important and where it's making sense to think about a regimen which can be longer is organ preservation, because we have seen that in organ preservation, larynx organ preservation, not only survival is the goal, function and toxicity are other points. And if I see the data from Arlene and our data in the Delos trial, we see that induction on the one side is a longer regimen, but on the other side we have less toxicity, at least in the late observation of our patients. We have much less swallowing problems, much less speech problems if we do induction, and after induction the radiotherapy. And this is one very important point which is coming up. You by yourself presented yesterday this very interesting toxicity analysis which have to be more and more in mind and in the midpoint of discussion, and Chetin pronounced that we have to look after years what really is the coming out, and I'm convinced that especially in organ preservation maybe induction is a very important goal for better functionality. But I really can't say it now, but our experience in the German trial goes in the same direction. So I would like to focus not only on overall survival. We have to focus on functionality and what is less toxic for the organ we really would like to preserve.
Reinhold Knecht, please, your opinion.
I think the most important thing, if you combine induction chemo with radiochemotherapy, with a time frame. We have some experience with our study, Lung and Protect, and we have seen in many patients if the time is more than 3 or 4 weeks between the induction and the radiochemotherapy, then results will be completely different. So that is the main point, what you say. If you do such studies, you must interact very good, the oncologist and the radiotherapist. If you have a treatment delay, then this therapy doesn't work, and then my sense is better to perform a primary radiochemotherapy.
Alain?
Well, I think we have to think about what is really the goal. There were 2 takeaway points that I take from all the induction trials that were done, induction followed by either radiation or surgery and radiation. And one is that the induction did not improve local regional control. So the only study that showed some effect on local regional control was the subset analysis of the Pacaniello study that Dr. Posner showed in his talk of the unresectable patients. All of the other studies, including the JETEC study, where there was a survival difference, but I've not been able to understand that study because there was neither improvement in local regional control or distant metastases in the arm that had the superior survival. So I've never quite been able to understand and explain that's the positive nature of that study in contrast to all other studies that have been done. So when you take 30-plus studies that have been done with induction followed by local therapy, and there's only one subset analysis that's positive, I have a hard time for local regional control. I have a hard time saying that this is going to help with local regional control. But there are a number of studies that show that it has had impact on distant metastases. So if we're going to use it and add it on to, which is the sequence that Dr. Posner is talking about, we're taking already a very toxic chemoradiation. We're going to add additional 3-drug regimen, which the toxicity persists. So it's not that you give these drugs and then all of a sudden those are out of your system and now you're going on to chemoradiation. You have that drug that's hanging in the tissues. So you're gonna ratchet up the toxicity again. So I have a lot of concerns about saying that this would be this should be used without further investigation and demonstration of benefit. And if the goal is really to help with distant metastases by adding the induction, then we have to select the patients who are at greatest risk of developing distant metastases.
Are there any comments from the audience? Yes, please.
How can you imagine the less toxicity of TPF versus PF? This is my first question. And the second one is, what about the late effects of TPF?
Well, 2 answers to that. First, because of the reduction in the 5-FU dose, I think you see less mucositis during the induction regimens, and that's where a lot of the toxicity develops. Patients become dehydrated because they can't swallow through the mucositis. The length of the mucositis with PF is quite a bit longer than it is with the TPF regimens. There's also, surprisingly, PF causes neutropenia, which is delayed. When you give TPF, the neutropenia is actually quite compact and early on in the treatment, so there's actually less toxicity in general and less delay in therapy with the TPF regimens. And this will come out in the analyses when they get compared, particularly in the TAX-324 trial. I do have some toxicity data from the early analysis, and that's in that data as well as in the HIT study. So the 3-drug regimen actually turns out to be less toxic than the 2-drug regimen, in part because of the 5-fluorouracil, which is the more troublesome of the treatments and the one in which we really can't manage the toxicity particularly well. And the second half of your question, if you could remind me, was late effects. We have over 100 patients that we treated. 70 of them are alive, and there are no late effects other than some mild deafness and some grade 1 neuropathy in our patient population from the taxane platinum 5-FU treatments. And taxane regimens have been used as adjuvant therapy for breast cancer for many years without the kind of long-term effects we see, for example, in cardiac function with adriamycin, or the bone marrow suppressive effects of the nitrosoureas or Cytoxan, the Cytoxan, which is a DNA damaging agent. So I think all in all, the platinum does cause some late long-term bone marrow reserve issues, and some people can be very sensitive to it, but there are very few in the way of long-term late effects. Dr. Forstier did allude to the fact that there may be some additional effects on the radiation from the pre-existing TPF, and as that washes out of the system, there may indeed be some slight increase in the mucositis that the patients have. That we will see in the randomized trial and be able to assess, because it really is very difficult to assess that just by thinking about it and looking at it in a phase 2 trial. I also point out that we have pretty good, robust phase 2 data, and we can make some extrapolations based on this data of what we assume can occur. That doesn't mean that the randomized phase 3 trials are not necessary. They have to be done because many times we've assumed things work that don't. And among those, chemoprevention. In head and neck cancer, we've used 13-cis-retinoic acid, vitamin E, and beta-carotene as chemopreventives, and none of them work when tested in randomized phase 3 trials. So we do need to do these as an absolute test of efficacy. But it's still, I still think it makes considerable sense, and I think it's primarily, and I think the failure of induction in the past, is primarily a result of the poor design of many of the early studies, and I don't mean that as a criticism of the investigators, but it was the state of the art of the time, and also the lack of really good regimens other than PF, which are included within the meta-analysis. And finally, the inclusion of carboplatin in some of those studies as opposed to cisplatin, where we have data that clearly shows carbo 5-FU is inferior to cisplatin 5-FU.
Dr. Clay.
I think there's also another reason between the toxicities. We have several different dosages that we use in TPF chemotherapy. For example, the Vermorgen study is 75 milligram cisplatin. You normally use 100 milligram per square meter. And I think that's the reason of many differences in the studies, that they use the TPF chemo, but they use very different dosages.
Yes. The TAX-324 trial uses 100 milligrams of cisplatin and a slightly higher dose of 5-FU, so it's a little bit more aggressive than the ORTC trial, TAX-323. So we actually, in our analysis, we saw the same incidence of grade 3 mucositis, but the duration of mucositis was far shorter than it was with platinum 5-FU, which is because of the less number of days of delivery. So generally, the ability to drop the 5-FU down and also the platinum in the European studies really resulted in the reduction in toxicity, because neutropenia is easy to manage. It's quite easy to manage compared to the other more systemically difficult toxicities.
I would just very shortly know what your opinion is concerning the efficacy of the carbotaxol versus cisplatin 5-FU. You said you are convinced that carbotaxol is not as effective as cisplatin 5-FU. What is the opinion of the other panelists here?
Well, I agree with that. I think that head and neck cancer is one of the few cancers where I think we feel pretty confident that cisplatin is a better drug than carboplatin, and that so I reserve carboplatin for people who have contraindications, neuropathy, renal damage, hearing loss.
And the Taxol component?
Taxotere versus Taxol, is that the question? My sense is that Taxotere is a better drug, but we have no comparative data.
I think Taxotere is easier to perform, better than Taxol.
I think we really can give an answer in about 6 or 7 years.
I agree. I don't think there's any randomized data.
Any comments from the audience so far? Okay.
I have a question to Dr. Forestier. You mentioned that probably we should select our patients better, the patients who get distant metastasis, in order to enhance our therapeutic ratio. Could you give us some suggestion on how to do that? And second, do you think microarray analysis or other forms of analysis could play a role in that?
Yeah, those are excellent questions. I think that we're looking at a small difference. So I think we're looking at, if we're talking about distant metastasis and you look at the trials with chemoradiation, you're talking about a 10 to 15% difference. So we're talking about a distant metastatic rate of about between 10, 15, 20%. Okay, so if you want to reduce that, we're probably looking at a small difference. So I think that this should be reserved for people with bulky neck disease, and that would be the group that I would include in these studies. So I would be looking at N2B, N3 disease, and perhaps T4s, T4, N2, or N2B, N3 disease. If I were able to design a study. And I would also test it first in the unresectable population, which is, that many within that category might be in the unresectable. I don't quite understand what we're going to learn from studies that don't distinguish resectable for unresectable and that are integrating surgery, and maybe Dr. Posner can sort of comment on that. I'm not sure how we're going to sort out the results in the end if there is a small difference. Studies, I think, are going to need to be quite large to be powered to look at who's benefiting from it within that context. The question about microarrays, I think that I also think that by just adding in more chemotherapy and potentially ratcheting up the toxicity is not going to get us very far in the long run. We may see some small incremental gains, but I really think until we identify some molecular predictive markers, now we have EGFR and we saw some data yesterday on expressors, until we have some better markers that will allow us to really subsegment these patients into risk categories, I'm very concerned that we're just going to escalate toxicity and not make a whole lot of, not have much gain in survival, overall survival.
I think okay, yes, go ahead. Fritz.
Dr. Posner, you made some short comments on the role of surgery after induction chemotherapy and radiochemotherapy. What's the role of surgery in partial remission and particularly in resistant disease in the neck?
We use our surgical colleagues work with us to remove the residual disease in the neck primarily. And then if we have recurrences in the primary site, generally we can salvage those sites if they're in the oral cavity or the larynx early. And if there are late recurrences in the tongue as well, we can see some salvage in those patients because we follow them relatively closely. I prefer to use a surgical approach in anterior oral cavity lesions because the reconstruction in that area is quite effective and patients can have a good functional result. But when you get into bulky disease and multiply enlarged lymph nodes, I think it becomes difficult because the prognosis is poor, and in those settings I prefer to use a chemotherapy approach with surgery reserved for recurrence or for persistent disease. I think the role of the surgeon is moving away from the attack on the larger cancers, T3, T4, N2, N3 disease, because I think we're at least as effective, if not more effective, with the chemotherapy and radiation approaches in terms of survival as well as local control. And I think that we're going to see surgeons going more towards salvage treatments, second primaries in patients who've been irradiated and develop recurrences, where it's going to be more challenging to do the surgery, but the indications and our ability to cure the patients without surgery is quite limited.
I think the intriguing option of neoadjuvant treatment is that after the induction block, we have a re-evaluation and can kind of sort out patients in laryngeal cancer at least who not further will be treated by chemoradiation but will go to the laryngectomy arm. But when we use this option, induction chemotherapy, now also for oropharyngeal, hyperpharyngeal cancers, what will be left of this option of surgical option, I think? Could you please make a statement?
I would not agree that we can still state that after induction there's a kind of selection which patients fit for radiotherapy or which fit for better surgery. Because I think Arlen, we discussed it last night, saw this effect that she had about 50% of the not partial remissions who were recommended for surgery refused surgery, and they had radio or radiochemotherapy, and a lot of them really did very fine. And we saw the same effect in our DELOS trials in Germany, that they refused laryngectomy, and they had this conservative regimen, and they did very well. So I think from an ethical point of view, that would be interesting to discuss in the panel and with the audience. Induction chemo as a kind of selection marker for surgery or not. That is becoming more and more difficult to really to keep on fashion, I would say.
Yeah. In the original VA trial, the surgeons had an examination under anesthesia of the patient after induction regimen and biopsied these lesions, and 45% of the partial responders were biopsy negative at that time. Yes, it was a superficial biopsy. It was only a testing of what was there, but it had a biologic impact if you analyze the data for local regional control. Those patients who had a negative biopsy actually had a massively different outcome in terms of local regional control. So this is for larynx cancer. So what this showed me was that it was very hard to assess this by clinical examination or by radiologic assessment. And I also point out that one of the reasons that you can use induction chemotherapy to select patients is that you might want to enhance the aggressiveness of the radiation. And I consider accelerated concomitant boost radiation fairly aggressive, whereas once-a-day radiation has, I think, substantially less toxicity in our hands for the patients. So you can increase the chemotherapy and the radiation effects for local regional control in these patients, which I'm sure happen in some of the larynx cases.
So this kind of a stratification, according to the response to the panelist opinion, is not valid anymore for the decision of surgery or not.
No. Yes, I agree to you because if you make the PF regime, you have a complete response at 20%. If you combine TPF, you have complete response up to 40%, an overall response rate 80-90%. And from the ethical standpoint, you cannot make the decision on the TPF chemotherapy. I would think we have performed the lung protect study in the partial remission and complete remission. We perform radiochemotherapy afterwards, and only in the case of stable disease, then we perform laryngectomy.
Yeah, stable disease or progressive disease, I think, requires a different assessment. But in those cases, there's grossly residual disease present. It's not a matter of some regression and then a distorted anatomy that you can't really tell what's going on in the patient. Those patients with gross residual disease, it's fairly clear, and we do laryngectomies in some of those patients, and they come back very rapidly with chemoradiotherapy postoperatively. Or we give a very intensive chemo-RT program.
Arlen, has this been taken into account for the planning of the new studies already? This fact, what you also said yesterday?
In terms of larynx trials? Actually, there is there's not, we don't have much agreement at the moment on what direction to take with larynx studies because of the organ preservation rate of 88% that was seen in the 9111. So it's going to be difficult to improve upon that. The only group right now that's advocating using induction chemo as a selection factor is the University of Michigan, which has an experience of giving one cycle of cisplatin 5-FU, and then based on the response to that one cycle of chemotherapy, deciding whether to perform surgery or go on to chemoradiation. And they actually have just reported that data in 90-odd patients with very impressive survival, but a lower rate of larynx preservation.
I just point out that I'm not recommending a sequential or induction regimen program for patients with, intermediate stage disease. And I consider, T2N0, T2N1, T3N1 disease, T3N0 as intermediate stage disease. Those patients do reasonably well with chemoradiotherapy. The risk of distant metastases tends to be low, although in piriform sinus, stage 3 disease is quite difficult. In those patients, because of the site, we do recommend a more aggressive regimen. So we use for stage 3 larynx cancer patients a concurrent regimen rather than an induction regimen if they have a T2N1 or T3N1, T3N0 lesion, depending on the volume.
I think we have to stop now because otherwise we take too much of the time of the next session. Thank you very much for all the discussions, and thank you very much also for your contribution of the audience, and I close this session.